Good evening and welcome to our live call-in show from Cardiovascular Institute of the South at Appaloosa General Hospital. This is our monthly live call-in show, broadcast the second Tuesday of each month. Tonight's discussion is a very exciting topic that is dear to my heart and Dr. Fail's heart, as well as all cardiologists here. And I'm really excited to welcome tonight Dr. Fail, Peter Fail, who's one of my mentors, who's one of my senior partners. Is an interventional cardiologist with extensive experience in abdominal aortic aneurysm, both diagnosis and treatment. I also have a regular on the show, Dr. Arzola, who's a non-interventional cardiologist with special interest in echocardiography. I want to give them both a warm welcome, and Peter, welcome to the show.
Thank you.
Thanks for having us.
I just want to start off discussing about aneurysms, which roughly about 200,000, just a few stats, about 200,000 aneurysms are diagnosed each year, of which somewhere about 15% are of rights of the size big enough that is dangerous if not addressed immediately, and it is somewhere about the 13th leading cause of death in the United States. Statistically, if you look at it, aneurysms are more common in adult white males, typically approaching 60, 70 years of age. Less common in African Americans. Ratio of men to women is somewhere about 2 to 1, with men having a higher incidence, and women catch up in the later years of their life in incidence as well as the prevalence of abdominal aortic aneurysm. And to talk about aneurysms, most of the audience may be wondering what an aneurysm means. Here, tonight's discussion is about the aneurysm weakening of the aorta, or the large artery supplying the blood flow to the entire body, below the level of the kidneys, wherein if you assume that the natural diameter of this artery is somewhere upwards of 2 centimeters, about 2 centimeters in a large adult male, and women it could be 1.5 to 2 centimeters. The weakening or bulging of this, ballooning of this artery approaching 3 centimeters or greater, and then as it approaches up to 5 centimeters, you're really worried about treating them. But any increase in diameter, somewhere about 2.5 centimeters, approaching 3 centimeters, should be of concern. So that is the discussion tonight, and I want Dr. Fail to make some opening remarks about his lengthy experience in the field of cardiovascular medicine, and in general where the treatment has headed in the past 20, 30 years of our experience in.
Yeah, well, I think that there's a couple of things that you brought up, I think, that are important with aortic aneurysms. The first of all is that, as you approach 3 centimeters and you have a diagnosis of an aortic aneurysm, the important part of that is the fact that it's also considered a coronary artery disease equivalent. And so the important part of the aneurysm is not the aneurysm itself, but the milieu or the disease process that got the aneurysm. And that's usually hypertension, high cholesterol, smoking, et cetera. So I think that those kind of patients are, although we may not necessarily do anything about the aneurysm themselves at that point, we want to start screening them for other vascular beds. And so that's the first point. The second point is that as they approach 5 to 5.5, depending male or female, there's been sort of a paradigm shift. And years ago, you remember that when we got to a certain size, we would evaluate them for surgery, and the surgeons would look at them and they would take them to surgery. And then as the stent grafts became available, what would happen is if they were not a surgical candidate, either because they had bad lungs or a bad heart or something of the nature, they would be sent for a stent graft. And so we would do the patients who were really considered high surgical risks. Over the past 10 or 12 years, what has happened is sort of a paradigm shift where now we tend to do the anatomically suitable cases with an endograft first, and then should they fail that, should that not be the case, if they're not anatomically suitable, if they have a large neck or no neck, or if they have some access issues that become a problem, or if their aneurysm extends above the renals, then we tend to typically send those to surgery. So I think what you've seen across the board around the United States is that, back in year 2000, 1998, 2000, we probably saw 10 or 20%, not even 20%, probably 10, 15% of the aneurysms were fixed by endograft, the rest by surgery. And I think now you're starting to see really a big flip-flop where probably in the neighborhood of 75% of the aneurysms are fixed with endograft and only 25% are fixed surgically as we move forward.
That's a very quick summary of where we are and how we are approaching the problem right now. And I want to just kind of ask Fernando, as a cardiovascular specialist, in his clinical practice, in any cardiologist practice, and who are the patients that we suspect, and when do we really, because as all of us while we talk about aneurysms or bulging of the artery, as most of us know within this field, that is completely asymptomatic to a large extent. So I'm like, what are the patients when you walk into the office? When are you concerned about a patient having abdominal aortic aneurysm?
Usually you're going to find a white male who has had a family member that has had an aneurysm. That's a smoker, has high blood pressure, coronary artery disease or vascular disease also. People that may complain of a vague abdominal discomfort, it's rare. Most of the patients that present with a AAA is what we call an abdominal aortic aneurysm, are asymptomatic. We had one that was spectacular, 7 centimeters in diameter in Morgan City when I worked there, that was found because he had a car accident. And somebody did an x-ray of his belly and they found this large shadow, so they did a CT scan and lo and behold, this 7 centimeter aneurysm of the aorta was sitting there. So most of the times you're not going to see it. We tend to be more suspicious of it, and at least I attempt to do these evaluations, an ultrasound of the belly, at least to any male 65 years of age with high blood pressure, smoker, and at least once. Scan the belly, see if there is an aneurysm, then if there isn't anything, you leave it alone. But mostly people that have family members that have had one, and they're going to be males. And like you said, once they get to the age of 80, it becomes a one-to-one, male and female. In women, it's more in the age of 60 or above that you're going to see these things happening there.
You know, I think that you bring up an important point, and something I think that sometimes in cardiology we get focused on. We get focused on the aneurysm, and we take care of the aneurysm, whatever the case may be. But I think it's also behooves us as cardiologists to say, you know, your family members need to be screened. And so I'm in my practice, I'm very diligent about saying, you know, you have an aneurysm that we need to deal with, but your relatives also need to be screened, specifically males if they're smoking, if they're of age.
Correct.
That's an important thing to do. Now, obviously, you don't have to screen a teenager, but I think a lot of times we see, you know, brothers or stuff. In fact, I have a lot of brothers in Homa that each brother has an aneurysm, and each brother was told the other brother who had an aneurysm, and we actually fixed all 4 of them together with endografts, which is sort of a little bit of a record. But I think that's really from our standpoint that we really not only say, you know, we know historically that if you had a family member that you may have an aneurysm, but we also have to make sure that we're telling that family you need
Their
to be
family
screened.
members,
Exactly.
And I would say if a member has an aneurysm, don't wait until they're 65 to check them.
Right.
If it's a male, you take them if they're 50,
Right.
and they have high blood pressure and they're smokers. You want to check those individuals, and maybe even do a serial screening.
Right.
I don't know what the ACC right now says specifically with doing that, but at least my said would be if you don't find anything at the first screening, then maybe 5 or 10 years later you need to repeat it.
Yeah,
and see what's going on.
I would believe that if you saw a normal aorta, a relatively normal aorta at age 50, I think you could feel comfortable they probably don't have anything, but I don't think it would be wrong to repeat that scan in 10 years.
Yeah,
I don't think it would be wrong at all.
Yeah, and I guess before the advent of CT scanning, which we now consider to be the gold standard of screening for abdominal aortic aneurysm, diagnosis, confirmatory diagnosis, it was really hard to pick up. I remember in med school and elsewhere, like if you were digging in the stomach, and once in a blue moon, you'd find you could actually palpate if the patient is of medium body or if it's a thin person with abdominal aortic aneurysm, you could actually feel the pulsatile aneurysm, or even sometimes rarely you can even see the pulsations. But that is extraordinarily rare in our patient population in Louisiana,
with our abdominal
or
birth, right?
in general in the broad American populace of this age, because we are talking 50, 60-year-old males. I mean, if you assume that the incidence of obesity is reaching serious epidemic proportions in this country, diagnosing it by physical examination seems to be less and less likely. So to Fernando's and your point, any patient that encounters internists or us as 50 or above, and if they have the right criteria, high blood pressure, diabetes, high cholesterol, smoking, and cardiovascular risk factors, they're already a prime target for screening of abdominal aortic aneurysm.
Right.
And an ultrasound, which is ultrasound screening, which takes about 5 to 10 minutes, done simple, non-invasive, inexpensive, is a great tool to pick up the presence of an aneurysm. In fact, all of us routinely pick up aneurysms in screening.
Exactly.
And there on the education starts. But the other specialists who frequently send aneurysm referrals to us also are people who by default do order a lot of abdominal CT scans.
Correct.
Or like urologists, general surgeons who, for different reasons, order an abdominal CT scan with contrast. Lo and behold, you see an aneurysm which is totally unsuspected. And probably in this day and age, that's probably the commonest method by which aneurysms are diagnosed. So talking about aneurysms, so what is the risk of, we are talking about the aneurysm. So it's a bulging or ballooning of the arteries below the renal arteries. And if you say they approach 5 centimeters or above, it is dangerous and we need to fix it. So what are the consequences of unchecked abdominal aortic aneurysm? Do they have pressure? Do they have impingement or pressure on the adjacent organs, or what are the main risks of unchecked?
Well, I think you bring up the one that I think most people would fear would be just an out-and-out rupture, and I think that's something that we'll see on fortunately a rare occasion, but those people present to the emergency room in extremist abdominal pain, blood pressure extremely low, ashen, and they look sick. They look really, really sick. In HOMA, we have approached it 2 ways, where we'll do an emergency endograft or we'll take an emergency surgery depending on what the CT scan shows. But I think that's, that is still not the norm. I think the vast majority of those patients would present to surgery. I think the other thing that we look at sometimes in aortic aneurysms is what we call trash foot, where we'll see a lot of the clot and stuff that's inside the aneurysm will slough off and flow downstream. And then you'll have a clot in the leg or in the toes or stuff like that. And so when we see people like that who present with blue toes, we'll obviously screen for aortic aneurysms. You talked a little bit about impingement. That's less common, but definitely can happen as you have this conformational change of the aorta itself as the aneurysm tends to increase. But I think the big fear is rupture. I think that's really where, from a vascular standpoint, we say we're going to need to fix this person. I think our biggest concern is the rupture itself.
There are two other ones that we're kind of missing: the fistulas,
aortic-enteric fistulas,
the aortic-enteric, and the aortic venous.
Right.
That's right. I mean, as all of us know, we used to see a lot more of them when we were training 20, 30 years ago, before the advent of high level of CT scanning for various purposes. As things have gotten more sophisticated in treatment of prostate or treatment of other general surgical, CT scanning is being used far more extensively. By default, we are picking up a lot more aneurysms a lot more early. I mean, there used to be this dictum where if aneurysms came in with a rupture, close to 75% of them never made it to the emergency room.
Right.
Of those that made it to surgery, less than 50% actually survive. And those 50% that survive will have an enormously lengthy intensive care unit experience.
They still do. Even today, I still think
and
they
it's
do.
It's just a very catastrophic disease. And so the goal clearly is to diagnose them at a much earlier stage, and then talk about treatment options and what are the treatment options earlier on. So now that we talked about aneurysms and the risk factors and so on, what are, I think the ways for diagnosis are fairly simple. And if you don't mind, please go over some of the diagnostic methods we have.
Abdominal ultrasound, which is extremely simple. You have to suspect it or screen for it. Abdominal ultrasound is the simplest way for a screening method in the office. It's painless, quick. Like you said, it's fairly cheap. Once you identify it, then you have to go to the CTA. Preferably a high resolution CTA, so that you can identify the extent of the aneurysm, define the anatomy, so that whoever's going to treat